Welcome to Seniors on the Move. My name is Karen McKenzie, and today we are going to talk about skin cancer, especially for older folks. So listen, all right? I just want to introduce our guests, and thanks for coming in. I really appreciate it. And this is not an act. I really mean it. I really mean it. Linda Murphy is a licensed practical nurse. 50 years of experience, Linda. I can't believe that. Working in inpatient, home, and outpatient settings, and also in wound care and psychosocial support. That's what I'm really interested in. And anyway, just what changes do you see from, say, 50 years ago, 40 years ago? I mean, I know that's a long time. Do you see many changes?
Well, there's an enormous amount of change.
You wouldn't know where to begin.
Well,
I don't blame you.
It really, as we were talking about earlier, is just in nursing education. The elimination of the hospital-trained nurse. They don't like that word trained, but.
Okay.
And I think that was a mistake.
Yeah.
But they're also just patient-wise. You know, you look at people 50 years ago and today, you didn't have the people on medications that they're on today.
That's interesting.
Yeah.
I didn't know that.
All the metabolic disease. I mean, just obesity. There's so many changes.
All right, now before we go any further, and I have to apologize, I'm going to introduce you. I really do want to hear more, Linda. I do. Patrick Mulvaney is a double board certified dermatologist and dermatologic surgeon. He's on the faculty at UMass Chan Medical School in Worcester, Mass. His clinical and research interests are in the treatment of patients with skin cancer, and that's how I met him. And he completed his internship in internal medicine at Beth Israel Deaconess Hospital, his dermatology residency at Mass General Hospital, serving as chief resident in his final year, and fellowship in micrographic oncology at Brigham and Women's Hospital. And I'm sure, especially if you live in this area or have lived here, you're familiar with all those hospitals. They're top-notch. He's active in teaching, clinical research, community service, and administration, and currently serves as program director for the UMass Dermatology Residency. Dr. Mulvaney grew up in upstate New York. I hope you like it here with us.
It's great.
You have to stay here for a while.
Don't plan on leaving.
He currently lives in Boston with his wife and 3-year-old son, and what is his name?
His name's Landon.
Oh, nice name. Linda, back to you, dear. Just talking about changes, if there's anything that comes to your mind. The biggest thing I always think of is the uniform, and we knew a nurse was there in the room with us.
Yes.
There are scrubs now. They wear scrubs instead of...
Right. You don't know who is whom. You just don't, you know, because everybody is in scrubs. And you have your little tag that says who you are, but is someone 90 going to read that? But I do think, you know, when I was young, you worked very hard to get your whites.
Okay. What about today's technology? Are you finding that tough? I'm sure you've already learned how to use it.
Oh, it's a great tool.
But it is, isn't it? Yeah,
I mean,
it helps
just
a lot.
think back with a thermometer. You put a thermometer in someone's mouth now, and it's instantaneous. We used mercury thermometers, and if it was under the tongue, it was 3 minutes. You know, there were no automatic blood pressure cuffs, which I don't really like, as you know.
They say the old ones give the most accurate results.
Well,
is that true, or
yes.
Doesn't it matter that much?
Well, if you get a abnormal reading with the automatic cuff, they tell you to take it manually.
They do.
So I skipped that first part.
All right, that's good to know. Dr. Mulvaney, I want to go back to you and make sure I get everything in. Could you explain the double certification for both dermatologist and surgeon? Do you do surgery most of the time? You do?
Yes, it's a great question. So the board certification is a stamp and a certification that signals to the community and your patients that you uphold a standard and you've had training in the area that you are an expert. And that's really important. So the double board certification, in my instance, started with a residency training in dermatology and then the additional fellowship training afterwards.
Okay.
And the way I approach my practice and the care of my patients is that I have a tool set, and that tool set includes a surgical approach, and that's very important to me. However, there are other modalities that we have in our toolbox to help.
Do you have to
patients.
have had you know, the dermatology.
Yes.
You had to
Yes,
have that
it's a bit of a
first.
stepping stone,
Just
yes.
wondering about
Yep.
that. I had surgery with Dr. Mulvaney, and I had such a great experience, and that's why I wanted to have him on his show. And he thinks a lot of you, and so we wanted to have you on the show.
Yes, thank you for having
Said
us.
she's got great information. Anyway, the importance, I've got here the importance of psychosocial patient involvement. Is that what that means? You really get to know the patient? You look at the whole person. In
Oh,
other
you
words.
have to. You have to.
But years ago, did we do that?
Yes.
We did that then
Yes.
too, but what, in a different way or just the same way, talking?
No, I don't think so. You had to know your patient. You know, I like to know everything about a patient because it just helps you
Yeah.
as far as treating them. You know, from a young
The
age
more
to
you know,
now.
the better, I would think.
Oh, yes. Yeah, what is your, all right, you're in the hospital, what's your home situation? You know, what are you sending
Yeah.
this patient home to? Is there anyone there?
Yeah. Is stress a big factor in anything? When you
In
get-
anything.
in just about
anything.
anything.
Yeah, we have people that
Especially- yeah.
come in and they're anxious or nervous or
Mhm.
they're not sure what to expect, and it's our job to very quickly gain confidence and trust. And then
Okay.
also that part of it, as Linda said, is
Yeah.
understanding someone.
And that's
getting
how
to
I
know them.
felt, you know, when I was there. It was
That's
such a
very kind.
pleasant experience. It was great. As we get older, our skin changes. We get more things on our face. Could you tell us some of the most common problems with facial
Certainly,
cancer
yes.
and so forth?
So the biggest risk factor for skin cancer is ultraviolet light exposure that comes from the sun that we are having such a beautiful day here today and
Yeah,
enjoying.
it's perfect.
and in small quantities and for the right amount of time, it can be beneficial to our health. It stimulates the production of vitamin D, creates endorphins.
Yeah.
There's a real feeling of sunlight that helps. However, ultraviolet radiation causes damage to our cells and our DNA. And our bodies are constantly trying to find out where these little places of damage are happening and clean them up. But if you take enough of them, statistically, a few over time will get away, and they create small growths that are technically
those,
cancerous.
That's what
Those,
I
the
really
growths,
want to
yes.
get into.
And there's a couple categories. There's a large bucket of what we'd call benign or non-cancerous growths, which don't need to be removed.
Is that more common?
That's a good question. Yes, they would be. If you had all comers, benign growths are more
Okay.
common, which is hopefully assuring to all the,
Yeah, it is.
the watchers
I
out there.
was.
Yes.
I was very much assured.
So just because something is new or concerning doesn't necessarily mean that it's a problem. However, there is certainly an epidemic of skin cancer in our country, and there's several million cases of skin cancer every year. There's another bucket and many other small divisions within it, but the three most common types of skin cancer are basal cell carcinoma, squamous cell carcinoma, and melanoma. So those are three words that we all become very familiar with, and those are the spots that we treat most commonly in our center.
Okay. Could you explain briefly the surgery you did on me and why and so
Certainly,
forth?
absolutely.
Thank you.
So one of the best techniques that we have to offer, I think in dermatology, if not in medicine, is this technique called Mohs surgery.
Yeah.
It's named after the surgeon who developed this technique back in the 1930s. So if we're talking about things that have come a long way.
I was surprised to hear that
Isn't it?
long ago. You know.
Yeah, and he was a general surgeon who developed this technique, and it's undergone some iterations since then. But the basic principle is that it's a technique that allows you to cure a skin cancer by surgically removing it and then examining the spot that you've removed pathologically, which means under a microscope. So, for instance, if someone comes in for a spot on their cheek, we would examine the area, remove what looks like a residual skin cancer with a scalpel, and then examine that tissue under a microscope while the patient waits to determine if we've gotten it all or if we have to go back and remove some more. But the technique really allows for very precise control and also a minimization of the amount of skin we need to remove in order to cure. So places that it's really effective are on the face, the neck, places where you don't have as much skin to give, if you will, and you want to make sure the spot is as small as possible.
Yeah.
And it's also useful for a subset of more aggressive skin cancers, which we want to make sure we get the first time and don't have any problems with afterwards. So it's a very highly technical removal of a skin cancer and also minimizes the footprint.
And how do we protect ourselves?
That's a great question. An ounce of protection is worth a pound of cure, as they say, so it's never too late to start. The sunlight is most intense in the midday, so for patients who I'm counseling, I always say the first thing you should consider is avoidance. And that doesn't mean you need to be a hermit who lives under a rock and never sees the light of day.
Yeah.
But if you're planning your activities early morning, later in the afternoon, you're just getting less ultraviolet exposure in those settings, so it's safer for your skin. If you need to be out during the higher intensity exposure times, they make really good sun protective clothing now that can get down.
That's true too.
Yeah.
It's a little more expensive.
It is,
Yeah,
it is.
but it's
again,
worth it.
worth the cure.
Yeah.
And it's nice because you don't have to apply anything and it's just there as a cover. So I'm a big fan of those. And then sunscreens as well are really effective at blocking the ultraviolet
never-
radiation that comes. So yeah.
Cosmetic-wise too, I know you can
Mhm.
get some protection with that, or maybe wearing a hat, that kind of
Yep,
thing.
exactly.
I suppose.
exactly.
What experience have you had with skin cancers? What is your part of treatment? What do you do? Do you interview the patient afterwards,
well, yes.
or
So we bring the patient into the room, and then we go over a short history of,
Okay.
things like, do you have a pacemaker or a defibrillator, blood thinners, a whole slew of things that we ask them. And, we confirm where's the spot.
all
We
right.
get everything ready, the vital signs done, and answer any questions they might have. And then the doctor comes in and takes it from there.
So the two of you work together.
Very closely.
Yes.
Yes,
Yep.
absolutely. I couldn't do without Linda.
And what would you have had to do with what I had done? I mean, do you have the paperwork too, or do you check, every
So when you
patient that-
came in, you were brought into the room and they asked you a series of questions.
Yeah.
That's what I do.
That's what
Yes.
you do? I
Yep.
wish I had met
And
you.
then-
And we go over, which is really important, is the medication list. That is a thing with me, is everyone knows.
There's a lot of details, and what we do
Yes.
is we consider very
Yep.
safe, but there's many layers of protection which Linda provides at the beginning to make sure that what we're
Okay.
doing is safe. And then
Interesting.
during the procedure, Linda's someone who would anesthetize by delivering local anesthesia. She's someone who's with the patient in between while the waiting period is happening, oftentimes administering other medications we may ask for. And then at the end of it is a really, probably the most important part is packaging up and getting a nice bandage on there, and then reviewing the instructions at the very end, because the patient will leave our care for however long afterwards, and being able
That's
to take care of the wound
true.
afterwards is
And
really
when
important.
I came back, I was there, it seemed like just a minute. I thought it was going to be much longer. What about cosmetic surgery? Do
Yeah.
you do much of that, and what type, or which type do you?
Yes. So I only do cosmetic surgery in the context of skin cancer removal. There are many other procedures
Okay.
which you could say are corollaries or similar to them in terms of principle. And we keep a lot of cosmetic principles in mind when we're doing our reconstructions after
So you
surgery.
don't do it just for beauty, like all the movie
If
stars.
it could be incidentally a benefit from having something, but no, it's not. We don't do it unless there's an existing problem, which hopefully our outcomes speak for themselves and look nice. But it's not.
All right.
Not
His
without problem.
closures they're just wonderful. He does
That's
a
very nice.
wonderful, wonderful job.
Well, I
Again,
don't know
it's
if
a
you can
team.
see my forehead. I've got a lot of hair there, but it seems just about gone. Can you tell us what else you might be doing in the course of what you do there with the doctor?
With the doctor, well, when he's suturing the patient up, you assist with that, cutting of sutures,
Okay.
whatever is
I
needed
remember
at
that,
the
yeah,
time.
yeah.
Mhm,
All right.
exactly.
Okay.
You have to have a strong disposition. It's things can. It's not for everybody to be able to assist during a surgical procedure, and as we were saying before about experience beforehand, some of the things that we do are not for the faint of heart, especially while you're in the room. So people like Linda are seasoned in this and really experienced, and you can't
Alright.
operate alone. So you need to have a team like that.
You're important.
We have
Sure.
we have
Yeah.
a great team.
Yeah.
actually.
And anything, well, there's been a lot of new things medically. It's unbelievable, even with diabetes, which you know about
Oh, I
that.
know.
Anything else on the horizon that might be coming down? What about AI?
Yeah, that's a great question.
I know it's not always great. It can be used in a bad way too, but it's amazing what it can do.
Absolutely. I'll answer the AI question. I can talk about a couple other
That'd be
points as
great.
well.
Thank you.
AI will transform medicine in so many different ways. I
Mm.
think it's inevitable, and being part of the change and proactive about it is probably the best approach, in my opinion. Ways that it can influence skin cancer detection and treatment I see are in the detection of lesions of concern. We've got great photograph capabilities, and if you train a model to be able to detect, they have very high
So you can
accuracy.
see things sooner? Is that what you're telling me?
It could be used at a population-based level, and
Okay.
there's multiple approaches to trying this. I think finding the right exact one is going to be the next question, but the computer can do things very well in terms of saying this is bad or not and getting to patients to where they need to be. Unfortunately, they don't do biopsies or surgery yet, so that's still some job security for us, and we'll be hanging on to that until they figure out how to tell a robot how to do it, which may happen, and that's totally fine. But that's one area. The other area is in the interpretation of the slides, as I mentioned before. So those are pictures,
That's a lot of
essentially.
responsibility. You
Yeah.
folks have a lot of responsibility.
We think it's fun. We enjoy
There's
it.
a lot.
Take it
There's
serious.
a lot involved in dermatology.
Yep.
But it is fascinating.
Mhm. And so when we read the slides that are prepared from the skin tissue that we remove, it's my eyes and my staff's eyes who all look. A computer and an AI-generated algorithm could probably do that better if it was trained properly.
All
so that might
right.
be the future of this, and it'd be highly reliable. It's a matter of implementation, though.
Okay. If you could give our seniors some good advice,
Yeah,
how often should they have a checkup
that's a great
for
question.
for skin cancer?
It's very individualized. For all comers, it may not be necessary, although there are certain populations and people who have things that would make them more likely to need one. If you've had extensive sun exposure over your lifetime, if you enjoyed going to the Cape every summer, or you've been in tanning beds before vacations, or just outside in your job, whatever it may be, those are certainly big risk factors in getting a baseline.
Even if it was done in childhood?
Yes,
Even if,
absolutely.
Because I can remember being bright red and having the chills and getting sick. But I said, but I'll be beautiful in a couple of days. So it's really ridiculous.
There's a long latency period between the exposure and when the spot
All
will
right.
develop. yeah.
Most common surgeries for seniors, people over 50.
Yeah.
What would you say? What is the most common? What I had done?
Yes.
The MOHS.
Yep.
MOHS, do I have that
That's correct,
Yeah?
yes.
Yeah.
And again, we reserve that technique for areas of either aggressive skin cancers or in areas where you really want to minimize how much skin you remove. So you can get them on your belly or your back or some other place too that's seen sun exposure in the past, but
Yeah.
the MOHS technique is really the best for cosmetically sensitive areas too.
What would you say is your specialty? What we're talking about?
Yes.
It is. But you must do, I'm sure you do something else with all your training
does.
and that good mind of yours.
I do spend a good amount of time in administrative and teaching capacity, which I really love.
That's what I want to know about.
Sure.
Do you do any teaching?
Oh, yes. Yes, every day.
Oh, well,
Oh,
do
you
you mean
do
with
it-
staff or
it-
just patients?
Both.
Both. Well, both.
Both.
Yes.
You do.
Yes, a lot.
Okay, so you have to know your stuff.
Medical training is very apprenticeship, experiential model. So as you get closer and closer to finally doing what you will do forever, the more you do it forever. So we have residents, fellows, medical students who are all in various phases of their training. And as they get closer and closer to being on their own, they need to be given more responsibility in that process. So it's our job to understand where they are in their level and how we can get them to their next level. And we're always
It's a big
pushing to do that.
responsibility,
It's
I
great.
would think.
It's fun.
Yeah. Well, what else can you tell us about what you do as it applies to seniors? Do seniors get more of a certain type of skin cancer?
That's
It's
a good
not just
question.
here, I'm sure.
Yeah.
Tags, things like that. Of course, that's something different. Maybe I should have mentioned that.
I'd recommend, if you have spots that you're concerned about, that a baseline dermatology exam is important. It can be challenging at this day and age based on the amount of providers we have in our general area. We're in some ways lucky, in some ways there's still a constraint. Our practice has about 20 providers who are physicians, nurse practitioners, and physician's assistants, and then residents and medical students as well, who all work very collaboratively to diagnose and treat.
So many
Yes.
people involved. Let's see. What percent of seniors do have skin problems? I mean, are seniors your biggest, the most
Yes.
amount of people that you have?
There's a bit of a spectrum, but there's certainly the highest frequency in people who are over the age of 50, as there's a long latency period. There are some genetic syndromes that develop skin cancers in earlier parts of life. So we do have patients who are in their teenage years sometimes who are in our care, and those can be very challenging cases to manage. I think the differences are that for seniors, for people who are regularly followed by their primary care and their dermatologist, they're in a great spot because they are often checked regularly and things are found early and small.
Yeah.
There are certainly instances where something is left longer than we would have hoped it to be, either due to fear about having it treated or uncertainty. And my message would be that if you're thinking about that or that's you out there, come and talk to us because we can at least tell you what will happen. And we want to do things when it's earlier and smaller as much as possible, at least have the conversation if we can intervene earlier, because there is a latency period and there's a growth period, and sometimes things can stay for a long period of time, but I think everyone wishes they had come earlier when that's the case.
I know, they wait and they wait. What would be the symptoms? I mean, there must be some things
Sure.
that tell you it's time to go. Is it,
Yeah.
would it be an itching, or would,
They do become symptomatic. Squamous cells and basal cells may itch. They'll bleed. They can get closer to areas around the eyes, the mouth, the nose, or the ears where they become impinging on functional abilities. Although some of them are asymptomatic. Some of them are just a spot that's been there for a long time. But if anything bleeds on its own without being injured, or if it itches or is painful or is
Yeah.
growing very quickly, those are all reasons to come see someone sooner rather than later.
So Linda, I'm sure this has been your experience too. You're together. Are you together
Yes.
most of the time during the week? And what was the position of some of the girls that were with me that day? Because they all seemed to know what was going on, and they explained everything
Yes.
else.
Yeah, we've got a great staff. It starts from
Would
the
they
very
be
first few-
CNAs, maybe certified nursing
Yep,
assistants?
medical
like-
assistants. But
Derm techs.
Yep. We
And-
call them derm techs, but they're functionally medical assistants.
Okay, so
who've been
that's
highly
part of the
trained. Mhm.
training then. All right. How long do they go to school? How long does a CNA study? Is it a year or two or something like that, or?
I'm not sure.
They have a certification program, but it's not
Right.
formal schooling. And every center is slightly different in terms of how they do it. Our MAs have all been with us for many, many years and they're in
Yeah.
doing the same thing every day. So for them, it's their training on the job. And I think that they wish they could do more because they know so much. So I often hear them saying, "Can you
True.
let me do that?" And
Well,
for
maybe
licensure and
they'll
legal
go
reasons, the answer is
on.
no.
Who knows?
They
Oh,
think-
they do.
Yeah.
They do.
So what did practical nurse mean years ago?
Well,
What is
same
the
thing in-
equivalent today? What is the
Well,
equivalent?
a licensed practical nurse is the
LPN.
same, yes, as
Okay,
it
so
was
it's-
50 years ago.
so
that,
it is.
that really hasn't changed.
All right.
Although we don't really work in the hospital anymore.
You don't.
No.
Okay, you
No.
did mention that to me earlier.
Right.
Would you rather
But-
not work in the hospital? Would you rather?
Well, I loved working in the hospital. I really did. But things happen, things change, and
We're glad to have her.
roll with the punches,
We're glad to
shall
have
we
her in
say.
ours.
And but ambulatory care is a wonderful place to work. I mean, when you figure I worked 40 years of every other weekend, every other holiday, and now I have every weekend off and every holiday off. It's like, I didn't know people lived this way.
Wow. So how many more years are you going to work? Probably as
I
long as you
don't
can,
know.
right? Because
I don't really have a set time. I do
Yeah.
love my job, and I think to myself, well, if I retire, what do I do? You know, I worked as a visiting nurse for a number of years, and I looked at people who were retired at home, and I thought to myself, no.
No, see that. I'm the same way. I retired
Right.
about 5 years ago. I worked in a retirement community. I was the fitness director there. But no, I'm still studying. I'm still reading.
Right.
I'm still learning. I take up something called Zentangle, which is kind of relaxing, sketching, and that kind of thing.
Oh, okay.
And I started a couple of talk shows, as you know. So I just keep going. But the challenge is to keep yourself healthy.
Yeah.
Would there be any kind of a special diet to keep your skin healthy?
That's a great question. There hasn't
Maybe
been-
water?
Yeah, water helps. You want to be hydrated.
Yeah,
Um,
yeah.
There,
Remember that. Yeah.
there isn't. I would say there's not high quality scientific evidence that any particular diet helps or hurts. So I recommend a well balanced one. I think getting all
Well-balanced.
well.
That
I mean,
fits everything,
Fits everything.
doesn't
It's
it?
not controversial. I do think that there's probably some help during the wound healing and recovery phase that protein is needed. So I encourage that if you're not
Yeah, we're trying to
getting
eat more
that and
protein.
vitamins and all of that in your diet. There are, I should mention, for those listeners out there, if anyone has been through this multiple times, there are some low risk, easy interventions that are oral pills that can help.
Really?
That are
That's
vitamin
interesting.
based too. So
Yeah.
there's some evidence that can help protect people
Great.
from future skin cancer if you've had enough of them.
What about skin color?
Mm.
Are their problems the same? Do they get these things later or not at all? If you're real dark,
That's a great question. So if your skin complexion, if you make what's called melanin, which is the pigment in the skin that makes our skin the color that it is, and if you make more melanin, your skin will appear darker. And what that's doing is it's reflecting the light and the ultraviolet radiation back out of the body before it can cause any damage.
Okay.
So for individuals who have darker skin complexion, they're protected from the ultraviolet radiation exposure to a greater degree than, say, I am. And your question,
Yeah.
all of us.
You're both fair, actually.
yeah.
Yes. So being inside's nice. To answer your question, the incidence and the risk is much lower for people who have more melanin in their skin,
Well, that's
but it's
good
not
to
zero.
hear, though,
It's
for
certainly
those-
not zero.
It's not zero.
So the people who need to worry about it more, who have darker complexions, are those specifically who have immunosuppressed immune systems. Most common reason for that would be if you have an organ transplant and receive medications that cause your immune system to be lower, or those genetic syndromes, as I mentioned before. And there's also an element of just bad luck sometimes. This is an example we talk about in our field a lot, but Bob Marley passed away of a melanoma, and he had a dark skin complexion.
Did I
Yep.
remember him? Sure.
So black patients and darker skin tone patients tend to get melanomas on hands and feet, which is a little bit atypical
All
from the
right.
general
Well, you
population.
know what? We have a minute left. If you want to add something, thank you so much
Yes.
for coming. You
Well,
did a beautiful job, and you have beautiful skin too. It shows beautiful skin.
It's a requirement.
Now, is your son? I'm sorry, you
Please.
go ahead. Is your son light?
He is,
Like
yes.
you
Yeah,
are.
he looks
So you'll
more like
have
me.
to be.
Yeah, he's got a little bit of a head start in terms of his skin protection. So he doesn't leave the house without having a good covering on. I just want to say thank you for having us. It's such a pleasure for us to be
yes,
here.
Pleasure.
Pleasure.
And I hope
and
I'll see
inviting
you
both
again,
of us.
both of you. I don't know if I want to see you.
You can
Well, I
have
was
any
gonna
time.
say-
Only socially.
Yes, of course.
There you
That's
go.
what
I'd
I
like
have
to
say.
meet your little son
Yes,
someday.
please be
But
great.
thank you, and thanks for coming.
You're
And
welcome.
bye for now. We'll see you next time. Thanks for joining us today.